Is that shared now?
That's perfect, thank you.
Okay.
I'd like to start by welcoming everybody to what is now our 10th UCD COVID Summer School Series. I realize that I keep forgetting to introduce myself, and there are people on the webinar who I may not know or who may not know me. My name is Fiona McNicholas. I'm child and adolescent psychiatrist in Crumlin, Lucina, and chair in UCD. And I'm delighted to co-host this webinar today with my colleague, Dr. Blónag Gavin and Paul Harkin. And the series of seminars are also being co-hosted by the College of Psychiatry in Ireland. Many of you will already know the format. It's a 45-minute talk by our guest speaker. There's the functionality for question and answers using your chat room. The chat option is at the bottom of your screen. If you would like to ask a question, send me either a private chat as the event is taking place, or raise your hand, mute yourself, and I can call you in towards the end of the session. Keep your mic on mute if you notice it has gone off, just to make sure that it's quiet for the rest of the attendees. So I'm delighted to welcome our speaker today, who's Professor Stephen Taylor. Stephen is coming from British University of British Columbia in Vancouver, Canada, this afternoon for us, and this morning for quite early for Stephen. So Stephen, I'm amazed at obviously how busy and prolific you are, because Stephen has over 300 academic publications. He's authored about 20 books, and one of them is the content of what he's going to be talking about today, which was published just in November when all was quiet and calm. And as well as being a very busy academic, being involved in teaching and research, Stephen is also a clinician. So he is Professor of Psychology at British Columbia and also within the Department of Psychiatry. So Stephen, I might let you say what the title of your book is and then take it from there. Thank you.
Thanks very much, Fiona. All right, I'll try not to make this go over time. I just hope the PowerPoint works. I started working on this in 2018, and I took it to my publisher, and he rejected it and said, no one's going to want to read this thing. And I was a little deflated and found a different publisher. The reason I started writing this book was in 2018, I started seeing a bunch of interviews with virologists and so forth on the centenary of the so-called Spanish flu. And they were talking about the inevitability of another pandemic. And I, out of curiosity, I started looking at it because my background is in anxiety disorders, obsessive compulsive disorder, what used to be called hypochondriasis, OCD, PTSD, and so forth. And the more I looked at it, the more I realized that pandemics are fundamentally psychological problems where people's behavior or lack of behavior influences the spread and containment of disease. And I realized that no one had ever put it all together. So I got interested in it and put this book together. And I knew a pandemic was coming. I didn't realize it would be so soon. And I thought it would be an influenza virus, although, you know, it's just a bit of fun. Well, it's not fun really. I chose the cover, and you can see here as a coronavirus on the cover. Who would have known? I would have thought it would be an influenza pandemic. Anyway, what I want to talk about today is the importance of psychological factors in pandemics, psychological reactions. I'm having some problem with my PowerPoint. I want to talk about COVID-19 compared to previous pandemics. You might know some of this already, but it's remarkable. This is, you know, deja vu. Almost everything we're seeing in this pandemic we've seen before or has happened before. I want to talk about our own research. We were fortunate. While most universities had their research programs shut down, ours was up and active, internet-based surveying, looking at people's reactions to COVID-19. And we found evidence of what we're calling, and now other people are increasingly calling, a COVID stress syndrome. I want to talk about that, our research. And I want to talk about forthcoming problems, particularly so-called lockdown fatigue and what is going to be, of course, the second wave. And the big problem that, at least in North America, no one is talking about yet is the problem with vaccination hesitancy. What are we going to do when a vaccine it becomes available for COVID-19 and a good chunk of the population, at least in North America, is not going to get vaccinated? And I've been asked to speculate on this a lot. Life in a so-called post-pandemic world. I call that post-pandemic, not post-COVID, because COVID might be around forever. It might not go away. Anyway, these are data from Ireland. When I was preparing this talk, I thought, well, what's happening in your country? And it turns out that what's happening in Ireland seems, as far as I can tell, and correct me if I'm wrong, very similar to what's happening here in Canada. So it looks like the curve, the so-called curve, has been flattened in Ireland, that you're gradually opening up, similar to Canada, but it sounds like similar to Canada, you're implementing mandatory face masks. So when I read about this, actually yesterday while prepping this talk, I thought, good, it's a similar situation to what's going on here, but I expect probably there are differences as well. Okay. Importance of psychological factors. As you know, behavior determines the spread and containment of infection. Beliefs influence health-related behaviors. Unfortunately, racist behaviors has been a factor in every major outbreak and pandemic that I've studied. I'm going to talk a bit about why that is a bit later on. We're finding that there are a segment of the population who are overreactors. They become excessively anxious, but there's also a segment, and particularly the younger people, are what we call underreactors. They think the whole thing is exaggerated and overblown. They don't see the need to socially distance and so forth. When I wrote this book, this was all new and no one really thought about this, but now we've lived through it. This is old news, I expect. There are a host of pandemic-related stresses. It's not just the threat of infection. Is the socioeconomic costs are huge. And perhaps for some segments of the population, the socioeconomic fallout is the biggest problem with the pandemic. Disruptions, the stresses of self-isolation. And there's been lots of speculation as to what predicts who copes well or doesn't cope well with self-isolation. We've been doing research on this. And it's contrary to the myth that introverts do well. That's not the case. There's a whole lot of uncertainty, and people who have a great deal of difficulty tolerating uncertainty are not doing particularly well during this pandemic. Uncertainty of whether it's over, and the disruption of social rituals. And you probably know this already, the disruptions of parades or annual events, or even something like disruptions of funerals or weddings. You've probably all experienced this where everything has become virtual. My day is full of Zoom meetings, whereas it previously would have had a few face-to-face meetings and so forth. So life has become increasingly digitized and to some extent unreal. Psychological reaction to pandemics. In a very real sense, the psychological footprint is greater than the medical footprint. And by that I mean more people are affected psychologically than they are actually infected with COVID-19, or know people who have been infected with SARS-CoV-2. And so, at least in our research, we've got population represented data on about 7,000 American and Canadian adults, and many of them are distressed, but hardly any of them have been infected or know anyone who's infected, but yet nonetheless they're distressed. So that's what I mean by the psychological footprint being bigger. Anticipatory anxiety, that's a typical characteristic of pandemics. If we look back to, there was an Ebola outbreak in West Africa several years ago, and that created an epidemic of fear in the United States. I remember actually going through Miami airport, and the television monitors had big signs about Ebola, warning about Ebola. And this was about 18 months ago. And I kept thinking to myself back then, well, wow, there are no cases of Ebola in the United States. You guys should be worried about seasonal flu. But that's the idea of anticipatory anxiety ahead of actual infection. Health anxiety, PTSD, and other stress syndromes. We're finding in our research that actual COVID-related PTSD is fairly rare, at least in our research, maybe 1% of people, but there are other stress syndromes that are more important and other sorts of things. What I worry about is cruise ship related PTSD. This is the Diamond Princess, which you might have heard about, which was not allowed to dock. It was in floating quarantine. I wonder about what happened to the elderly people with pre-existing medical conditions who were worrying about getting access to their meds, who were in these tiny cabins without a balcony, without windows, and were sequestered in quarantine for weeks and weeks on end with the uncertainty. That's a recipe for PTSD. It happened during SARS under similar circumstances. So I really hope these people are followed up to make sure that they're psychologically okay. As you know, pandemics are dynamic events, they're not static. These are Canadian data, and as you can see, February was the early start of the pandemic, peaked until April. We had in June, which I think is similar to Ireland, when we started to open up. But our problem, maybe it's your problem too, is we started to open up and then everyone said, oh yay, let's go out and party. And so people, particularly young people, were starting to congregate together, and we're starting to see a second spike. And that could become the next wave. The methods of managing pandemics are, as you know, it's hygiene practices, social distancing, vaccines when they become available, and as I'm going to talk about later on, vaccination hesitancy or outright refusal is going to be an important problem forthcoming. Risk communication is vital. Pandemics require people to do things. We have to agree to give up bits of our freedom to manage the pandemic. We all have to agree to socially distance and so forth. And so the risk communication from health authorities is vital in managing pandemics. It needs to be announced early, it needs to be transparency, there needs to be public trust. I want to give you an example. I think it was 2007, the Ebola outbreak in Liberia in West Africa. The people who did not trust the health authorities were not socially distancing. And we're talking about Ebola here. So public trust is immensely important. And as part of this, it's vital that the health authorities evaluate the impact of their communications on the community. This is an example from Las Vegas a couple of months ago. The mayor of Las Vegas declared, well, you know, this lockdown, the social isolation is immensely expensive. Why don't we just open up the town and let the virus go where it will? Let it cull the masses and we'll get some kind of, quote, herd immunity. And this was her plan. And it was met with major outrage that she would do this. She would put economics ahead of human lives, and that idea was shot down. So here's an idea about how important it is for health authorities to gain public trust. And these are US data. These statistics are available for most countries and not as bad as they are in the United States. The United States has become a case example in what not to do. These are approval ratings where 0 is neither approve or disapprove, 75 up here is approve, minus is underwater, it's disapproval. And you can see here that President Trump, the red line, his approval rating has gone underwater. Most people disapprove of what he's doing. Unfortunately, the CDC and where's the purple one? The WHO, their approval ratings have gone down too. That's partly because of the inconsistency in reporting. One example is around face masks. Around about February, everyone across the planet was being told, don't wear face masks, save them for the healthcare workers, you don't need them. And suddenly there's this 180-degree turn. We're all told to wear face masks. So that's created confusion and lack of trust in health authorities, and hence reduction in approval ratings. The problem with that is if the ratings go down, people are going to be less adherent to what the authorities recommend. This illustrates some of the challenges in risk communication. 1918, this is a newspaper clipping from Honolulu. They at that point had one case of Spanish flu, and you can see here the highlighted bit is health authorities claim there's no danger of serious epidemic, nothing to worry about here. Move along, there's nothing to see here. Just like President Bolsonaro from Brazil said, it's just a little flu. So when you get it wrong, that really undermines your credibility and people are less likely to do what you're going to recommend. COVID versus previous pandemics, there are so many similarities. Surge of anticipatory anxiety, the rise of racism and xenophobia, panic buying, both hospital surge and hospital avoidance, fear and avoidance of healthcare workers. And we're finding this is a big issue. It's largely been not talked about in the media, that many people are frightened and stigmatize healthcare workers. Talk about that a bit later on. Sporadic looting and rioting, the rise of altruism, conspiracy theories, mass rebellion, and our forthcoming problem is vaccination refusal. I'll take a little bit of a closer look again. And this, you're going to see that everything old is new again. And the sorts of phenomena we're seeing with COVID-19 have been occurring forever in previous pandemics. Quack to the future, excuse the bad pun. Quack cures and desperate remedies. 1918, so-called Spanish flu. There were quack cures about eating onions as a way of keeping yourself safe. We saw this same time around 2020, gargling with garlic. 1918, quack cures. I love this. I don't know if you can read this here. It says, refuse worthless imitations. I don't know, what is a worthless imitation of a quack cure? I don't know. Anyway, Dr. McKenzie's smelling bottle. In 2020, colloidal silver, which is silver in a suspension of oil or whatever. It's a bogus cure. If you go to the US FDA, Food and Drug Administration, they have a list of fraudulent disease products in which they issue cease and desist orders. And I don't know if you can see here, I typed in colloidal and it spat out a whole bunch of bogus products in which they tried to shut down, including this one, musthavemum.com, colloidal silver. Bogus products been advertised as cures for COVID-19. Occurred in 1918, we're seeing it a century later. Desperate measures. In 1918, people were drinking hydrogen peroxide, reasoning, oh, well, if it kills bugs, it will keep me safe from the Spanish flu. Not so, it'll make you very sick. And we saw that in 2020 when President Trump talked about what he thought was a game changer, chloroquine, which led to some overdoses and deaths. Oh, of course, that. Hospital surge. With COVID-19 and pandemic influenza, in the mild cases, there are lots of mild symptoms which people could misinterpret, which has led to overwhelming healthcare lines. The surge of the worried well into hospitals and clinics overwhelms the healthcare system. Here's an example, a study done in 2009, the so-called swine flu pandemic. 18 hospitals in Utah. They computed increases in weekly admissions before the virus actually arrived in Utah. That's the anticipatory period, but the community was aware of it, and then compared to the actual flu period. And they found that the biggest surge was in the anticipatory period, where people were misinterpreting minor symptoms, particularly in their children, and bringing kids to the hospital at an overwhelming the healthcare system. So you get both fear and avoidance of hospitals. Profiteering, here we have Lifebuoy soap trying to cash in on this. 1918, of course, we've seen this, mask manufacturers happy to cash in on this. McGregor's Final Scotch, a real tonic for the flu in 1918. Coca-Cola, this is a sign from Times Square in New York where they tried to pair Coca-Cola with best practices of social distancing. Staying apart is the best way to stay united, and drink Coke. Even the massage parlors were trying to get in on this. 1918, this is a newspaper ad, guaranteed to cure the Spanish flu. Boys massage parlor. Guess what? Nothing's different in 2020. You've got Massage Warehouse. 12 ways to come out of this stronger than ever. Fraud. In the United States and probably other places, people have been using identity theft to rip off people for unemployment benefits. Same thing happened in Chicago in 1918. This was a case of a nurse, so-called nurse, who was called Slick Julia. She went into the houses and ripped off people pretending to be a nurse. I love this final quote. And this is from the Chicago Tribune in 1918. With her rose-lipped smile and pearly teeth, she performed various miracles of getting ready money. So she ripped off the sick and dying. Everything is old and new again. Wear your masks, obeying the city ordinance. Mask rebellion. Now, I gather in Ireland that you've got to wear masks on public transport, similar to Canada. And correct me if I'm wrong, it's not being enforced, you're being encouraged strongly to do that, similar to Canada. We've got some provinces where it's actually mandatory, but they're not able to enforce it. Well, in the United States, particularly, and to some extent in Canada, this is mask rebellion, that people are refusing to wear masks, and it's become politicized in the United States. But you know what? It's no different from a century ago. There was the Anti-Mask League in 1919 in San Francisco, that, and the reasons they voiced back then were the same as the reasons for the anti-maskers today. They were saying, well, we don't think masks work and they're a violation of our civil liberties. Today, the reasons why people don't wear masks, these are Canadian data, but they're similar to other countries from what I've seen. That mainly people find masks, at least in Western countries, oh, they're uncomfortable, they're weird, I don't think COVID is a big deal. They're the main reasons. But what happens if you get people with a strong degree of psychological reactance, and that's something you see in highly individualistic cultures, where for some people, when they perceive that their personal liberties are being violated, there's a strong pushback. It's a kind of allergic reaction to being told what to do. I remember my son, when he was 3 years old, really messy kid. Kids are so manky. I told him to clean up his room, and he said to me, "You're not the boss of me." And I said, well, you know what? I am. So go clean up your room. This is a bit like psychological reactance. It's people in the community saying, oh, you're telling us to wear masks. You're not the boss of me. And they actually intensify whatever reasons they had beforehand when they've been told what not to do. So this is how mandated mask rules can backfire. However, that said, this reactance can rapidly fade. The Anti-Mask League in 1919 rapidly fizzled out. So this, I guess, emphasizes how pandemics are dynamic events. Mask wearing attitudes, compliance can change rapidly. In America, you've got, give me liberty or give me death, I'm not going to wear my mask. Today, in a month or two, if President Trump and Vice President Mike Pence starts wearing masks, suddenly all the Republicans will be wearing masks. So things change quite rapidly. I have this problem with my PowerPoint, it gets stuck. In the media, I thought the media is doing a fairly good job in reporting this pandemic. However, media tends to report very dramatic events like mask rebellions, and that can give people a distorted impression of the prevalence of these things. You see these rallies and dramatic video footage of people refusing to wear masks, but they are a minority. These are Canadian data, and here in Canada, only 13% refuse to wear masks. In the United States, it's a little higher, 22%. But I expect these numbers are roughly similar to other places in the Western world. Most people are okay to wear masks, and they will wear them if they think it's the right thing to do. You know, everything old is new again. Getting creative about masks in 1918, getting creative in 2020. David Lynch has his own characteristically creepy set of masks. Panic buying. In 1918, there was panic buying of Vicks Vapor Rub. And that was something that people rubbed on their chest with the idea that back in the time, if you put this rub on your chest, it helped free up the airways. It was a folk remedy of the time. It helped. That was the panic buying back then. This time around, of course, these are frame grabs of the toilet paper riots, people fighting over toilet paper, panic buying toilet paper. Or if you happen to be in Canada and read the Marijuana Business Daily, early on in the pandemic in Canada, there was panic buying of marijuana. Or if you live in the United States, it's panic buying of guns and ammo. There's a snowballing effect of panic buying. And this is my attempt to understand it. Health authorities or public figures tell people to stock up in the expectation of self-isolation or lockdown. That causes people to flock to stores. And you get a cohort of highly anxious people who overpurchase out of a sense of urgency and fear of scarcity. And we have data on this. It's only a small proportion of people who are highly anxious, but they're highly visible. And so it creates a fear contagion effect, amplified by dramatic images that go viral on the internet. So for panic buying, the purchasing is not driven by our fear that the supply chain will dry up. It's the fear of the behavior of your fellow shoppers. Oh man, I better go out and stockpile toilet paper, marijuana, or guns and ammo because my neighbors are going to buy it all up. And that creates natural scarcity in the short term. And that amplifies the sense of urgency and fear of scarcity. And inevitably, there's a corrective measure like limiting purchases or social shaming, and it dies down until the next cycle begins. Interestingly, in Australia, there's been a second wave of panic buying of toilet paper. Anyway, why toilet paper? Early on and now. Early in the pandemic, there were a few ways of coping. If you look back to February, it's quite interesting. We were told not to do anything but wash our hands, stop rubbing your eyes, don't pick your nose. And that was what we were told to do. We were told, don't wear a mask. And so there were a few ways of coping for anxious people, except for purchasing supplies. And toilet paper packets are large, readily identifiable items, so clearly visible in viral videos. And people with a high level of infection have a high level of disgust sensitivity. And of course, toilet paper is a remedy for disgust. So I think what happened is toilet paper became conditioned safety signals. And that was one reason why that went viral. Altruism and ostracism, features of previous pandemics. I did an interview a few months ago with a French journalist, and she said to me, oh, well, yeah, your book, you got a few things right, but you got the healthcare worker ostracism wrong. We've got this evening clapping of healthcare workers. And I said, well, yeah, you probably have this. I gather it's in Europe too. Each evening, although it's actually dying down, people are getting sick of doing this, applauding healthcare workers. Yeah, it's one thing to applaud healthcare workers from the safety of your home or balcony. It's completely different to come in contact with healthcare workers. And we've got research on a study that's, well, it's been provisionally accepted for publication. We're just revising it a bit. on fear and avoidance of healthcare workers during COVID-19. We're finding that there's massive stigmatization against healthcare workers. People believe that healthcare workers are highly likely to have COVID-19. In this sample of Americans and Canadians, it's, they believe that 30%, 45% don't want to be around healthcare workers because they're frightened they might get infected. Let me get this number right. About a quarter of people think that healthcare workers shouldn't go out in public and should have restrictions on their freedom. And about 30% think that healthcare workers should be separated from their families for fear of transmitting SARS-CoV-2. So there's this massive community stigmatization and ostracism of healthcare workers that we don't recognize because people, at least in the community, are thinking about, oh yeah, we go out and cheer them, so it's all okay. And the correlation between, I'll just skip through this very quickly. The correlation between fear of healthcare workers and cheering is 0.03, so it's essentially zero. So people who go out and cheer the healthcare workers in the evening are just as likely to be frightened of coming in contact with them. Important differences between this pandemic and past ones. This pandemic, of course, is the first one in the era of social media and global interconnectedness. So there's more rapid news reporting, greater social support during lockdown, greater opportunities for trolls, and wider spreading of fake news and so forth. This pandemic around, we benefited from lessons of the past, the naming of the disease. I thought the WHO had done a great job of naming this COVID-19. You don't name a pandemic after people, places, or things. President Trump calls it the China virus, which is a really bad name for a virus because it promotes racism, xenophobia, and social mayhem. COVID-19 is a nice name. We don't know about long-term neuropsychiatric effects of SARS-CoV-2. Conspiracy theories, I recognize I'm getting short on time. The conspiracy theories this time around are the same that we saw earlier on. They're all, conspiracy theorists live in silos or bubbles. And it's the same, these are recycled theories. The bioweapon, we saw that previously in previous outbreaks. Poor Bill Gates, I hate to be Bill Gates. A conspiracy theory in America, it was a bioweapon released by the Chinese against the Americans. Although if you look in the Chinese media, you'll see it's the conspiracy theory, it was released by the Americans against the Chinese. People who believe in conspiracy theories tend to believe in others. So if you believe COVID is a bioweapon, you tend to believe Monsanto created the Zika virus, NASA faked the moon landings, 9/11 was an inside job, and so forth. It's very difficult to correct conspiracy theories, but you can inoculate people against them. Internet trolls have been part of a problem. The WHO recognizes these are agents of chaos. They love intentionally antagonizing others, spreading false images, fake news. We saw it in SARS, fake news about Hong Kong being sealed off, led to panic buying and so forth. You might remember the bat soup thing where early on, I think it was about February, there was images being circulated about Asian people eating bat soup that fueled racism. Actually, you know, these bat soup images, they weren't taken in China, they were taken in Palau, which is an archipelago in Pacific Islands. But it was released by trolls to create mischief and mayhem. And trolls are essentially agents of chaos. And I want to read you this quote by Buckles et al., who researched trolls. Internet trolls share many of the characteristics of the classic Joker villain. They're agents of chaos. They like exploiting hot button issues. They enjoy making people look stupid or foolish. And they have psychopathic traits. And they enjoy humiliating others. They have what's called negative social potency. They enjoy causing social mayhem. So we've been seeing trolling. This pandemic Fortunately, the media is not giving a lot of attention to trolls this time around, which I think is great. So this is the best way of managing trolls. Don't feed the trolls, don't give them attention. I want to wrap up. I think I've got about 9 minutes talking about our research, COVID stress study. We have a Psychology of Pandemics network. It's across Canada and the United States, where it's not just a research network. We've got online self-assessments, and we're hoping to get an online platform for self-help treatment or guidance as well. So our study was a 3-wave longitudinal study, about 2 months between studies. It was conducted by Qualtrics, which is an internet-based assessment company. Man, they're expensive. We've done wave 1, we've done wave 2. We're only able, we don't have the money. This is a $500,000 grant. And most of the money goes to Qualtrics. We weren't able to assess all of the wave 1 people. We only had money to assess about half of them. We've got wave 3 currently underway. So what we aim to do is develop psychometrically sound scales. I just saw a typo there. Yeah. Identify patterns of stress and coping, vulnerability factors, and so forth. I want to talk about some of our findings. We're finding evidence of both over-responders and under-responders, and they're extremes of a continuum. One of our challenges is trying to identify cut-off points for identifying these people, and right, it's a continuum, so it's really challenging. We're thinking about 10 to 15% of people at each end. The under-responders see the COVID threat as exaggerated. They see themselves at low risk. They tend to be younger people, low distress, except in lockdown. They're distressed during lockdown and bored, and they tend to be non-compliant. And if you ask them if you get vaccinated, they tend to say no. We're finding evidence of a COVID stress syndrome, and that's based on a bunch of analyses of our COVID stress scales. The core features are these fears or beliefs. They're terribly frightened about getting infected, frightened about coming in contact with surfaces or things might be contaminated. They're frightened of the socioeconomic consequences. And that's the thing about this pandemic and past pandemic, the socioeconomic consequences are as big as the actual risk of getting infected. They have COVID-related xenophobia. They have traumatic stress symptoms, meaning they're having nightmares or intrusive thoughts about COVID-related issues, and are engaging in obsessive compulsive related check and reassurance seeking. Premorbidly, they have, guess what? A history of mood and anxiety disorders, elevated health anxiety. They see themselves as being highly vulnerable to disease, intolerant of uncertainty, and they have premorbid obsessive compulsive features and elevated xenophobia in general. So this syndrome has elements of generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, and illness anxiety disorder. We're following this up. We want to understand, is this just an adjustment disorder that will go away when the pandemic is over, or is it potentially chronic? But there's growing evidence of the clinical utility of this problem. If you have a high score on the COVID stress scales, you're more likely to engage in a whole bunch of things, panic buying and so forth. I've got 5 minutes, so I'm going to rush through this. Xenophobia is one thing I want to touch upon. The issue is, why does it commonly occur during pandemics? And it does. It's unfortunately a common feature. And why is it part of the COVID stress syndrome? Well, partly it seems to be an evolved mechanism because historically, humans are tribalistic, and we tend to get infected by nasty diseases that are brought to us by foreigners. In this image, explorers to the Americas brought smallpox, influenza, and so forth that decimated the indigenous people. So that's linked to this idea of what's called a behavioral immune system that is a complement to the biological immune system, that people are sensitive to sources of pathogens. So it's an evolved fear of foreigners or strangers. And for some people, people who are very frightened of getting infected, they have this heightened xenophobia. Coping with lockdown, we're finding, there's been a bunch of studies, not a lot of the results have been replicated. We're finding that fear of getting infected is the biggest predictor of stockpiling and distress, and interestingly, the use of personal protective equipment like masks and so forth. Second wave, in Canada, we're looking at a second wave. America, they haven't quite finished their first wave because of how things have been handled. But one of the concerns is lockdown fatigue, that you'll be an increasing non-adherence, and that's going to create problems. At least in Canada, one of the things we've been thinking about how we're going to deal with a second wave of lockdown fatigue is you can make stresses easier to deal with if they're more predictable and controllable. And if we use statistical modeling to make the lockdown more predictable, okay, you've got 6 weeks, you've got to tough it out. That's going to make it easier. And of course, financial assistance. And there are other things people can do. But this is a big challenge. I've got only a few minutes left, but we're finding that a lot of people are saying, at least in Canada and the US, they will not get vaccinated. And we know that vaccination hesitancy has been a perennial problem for flu vaccine, but it's going to be a bigger problem for SARS-CoV-2. And vaccination hesitancy for SARS-CoV-2 is predicted by pre-existing anti-vax attitudes. Problem is there's a lack of a track record for a SARS-CoV-2 vaccine. We don't even have a vaccine yet, and various sorts of concerns. So this is going to be a forthcoming major problem. Mental health services for COVID-19 have been largely reactive instead of proactive. Been a rise in digital services. We need more. There's the issue of whether it's going to be helpful for severe problems. We have on our website a self-assessment where people can complete the COVID stress scales and get feedback. There are internet-based cognitive behavioral programs. This one is from Canada. It's the Bounce Back program, which anyone can access these days. I'm going to finish this up in the last couple of minutes about some speculations of life in a post-pandemic world. You know, I call it post-pandemic, not post-COVID, because COVID-19 or SARS-CoV-2 could be here to stay. So we're going to be moving from this to this. This is the Mardi Gras in New Orleans. Most people are resilient to stress, but we know from natural disasters and from SARS that a significant minority of people will have enduring problems. We don't know about long-term effects of SARS-CoV-2. It's a weird virus with neuropsychiatric complications in some people. We expect there'll be an increase in germaphobes. Yeah, because OCD arises from a gene-environment interaction in our research and other research. So the environment here is the COVID pandemic. The genes are vulnerability factors. They're going to interact. We will see an increase in germaphobes. One thing we're looking at is whether there's going to be a rise in hikikomori, which was thought to be a culture-bound syndrome, but it's not. It's a pseudo-agoraphobic syndrome where people retreat into the germ-free safety of their homes or apartments. They retreat from the world into the safety of their homes. And we've got some data suggesting that there's been an increase in this, but we're looking at this further on our subsequent waves of assessment to see if that is a trend. So with that, the end. It's my Looney Tunes end. So look at that, I finished on time. So
brilliant, brilliant, Stephen. Thank you very much for that. My goodness, there was a huge amount of work that had gone into your book even before any of us thought about this. It's amazing. And I guess it's scary how similar the current COVID pandemic, you know, as you say, is so similar in many ways to SARS, but scarily more concerning on account of the fact not only social media increases fake news, but the ability to travel and to, you know, very quickly, you know, increase transmission is huge.
Yeah.
So it is a difficult time. I was wondering if you could kick off by just saying something about The difficulty we have at the moment, and obviously it's the same in Canada, you talk about the fact that it's post-pandemic rather than post-COVID, and that COVID-19 is going to be here for a while. But one of the things is preparing for it, is the uncertainty of what you're preparing for. All of us booked flights about a month ago because the government said we'd be able to travel places, and we almost had our bags packed. And now sadly we're looking at it and realizing actually that's probably not going to happen. In the same way, parents are getting excited that school is going back in September for us. And then there's wee little bits of caveats coming in, well, not as we knew it, full-time return, but not quite as we knew it. So bit by bit, the very things you thought, the pubs that were going to be opening are now not opening unless they have food. How do you help a population that is varied, like you say, into the extremes at either end, the non-believers and those that get very anxious? How do you help us all move forward and cope with the uncertainty, but at the same time make some kind of plans and keep ourselves, some reserves for, what might be new surges?
It's a really important issue. I think what needs to be done is we can come up with advice, but we need to pilot test the messages that we give out to people. We think back, the panic buying, our health authorities in Canada said, we're going to come into lockdown. They didn't call it lockdown then. You better stock up with a 2-week supply. And that seemed like sensible advice, but it had these unintended consequences that caused rush and panic buying. So whatever advice we give out to people, we need to pilot test it carefully, because what can seem like sensible advice can backfire. But I would think, that said, the first thing would be to help correct people's expectations. We're talking about a situation of, I guess in the animal learning literature, it's called frustrated non-reward. We're expecting a treat, some goodies. I've been through lockdown. I've been a good citizen. I've been in social isolation. Now I should be allowed to go out and travel and party and go to the pub. And now you're telling me I can't. So people will get frustrated. So having people understand that, but also trying to make it predictable. Trying to say, okay, all right, we're looking like we could be resuming lockdown, but based on the best available data, it's got to be 6 weeks or 2 months, and you need to do this in order for this to be over, and to get the message across to people. And it's going to be challenging, particularly to the young immortals, the young people who think they're essentially immune to COVID-19, which they're not. To get the message across that the more you party, the more you go out, the longer this will last. No one wants this to last. So that might help, but I got to be frank, I think the problem with this pandemic is it's a hidden pandemic. We don't see corpses around, we don't see coffins lined up in the streets, hearses are not seen. This is very different from the so-called Spanish flu, where they couldn't bury people because there were so many bodies. We don't see this time around. It's a hidden pandemic, and it's led many people, particularly younger people, to say, oh, this is all exaggerated. So that said, it's led to people thinking, oh, this is overblown. So I'm sorry to say, what's going to have to happen is it's going to get a whole lot worse. You're going to have to see your grandmother die. You're going to have to see your neighbors getting sick before people are going to start to take this seriously. I think that's what's actually going to happen, and it's starting to happen in the United States. Mm-hmm. Partly because it's so abstract. For many people, this is just something you see on your computer screen or on the TV. It's an abstract concept. Hardly anyone knows anyone who's become sick or died or been on a ventilator because of COVID-19.
It's interesting because we're putting so much on hold in order to deal with, what's in front of us. And you realize there's only so long you can do that. Life must go on, school must go on, college, applications for other grants that are not COVID related, seeing other children, you about preempting, more serious illness rather than just firefighting. And I guess, how do you allow yourself to do that? Keep a little bit of reserve for when you need to suddenly scale up again, but at the same time, keep going with your other plans, trajectories, you know, whether they're personal, work, or, you know, family, whatever.
You're absolutely right. My research as of December was on psychology of climate change, and I was doing a bunch of work on that. And when COVID broke out in December, I've done nothing but COVID, so my life has been on hold too. But I think the good news is people are resilient and adaptable. We've survived many pandemics in the past. My kids, which are, my daughter's 13, my son's 15, they hate online schooling. It's boring, they can't get focused. I'm hoping that they'll be resilient and adaptable like most kids. They'll figure out a way of dealing with it as, you know, the cliche, the new normal, that I'm hoping that most people will learn to adapt, will find ways around this. And here's my hope that, although I was really negative talking about the need for more deaths in order for people to take this seriously, I'm hoping that people will emerge from this past episode of lockdown more resilient. So if they have to go into a second wave, they'll think, okay, what did I do last time that worked? What didn't work? And they'll be prepared. Because there will be another pandemic, maybe an influenza pandemic, or we will have the threat of climate change to deal with. And I'm just hoping that this will be a wake-up call for people, that we can learn, we can realize that we are resilient and adaptable, we can learn to cope. And I think maybe a silver lining of COVID-19 is we're seeing that we can have an impact on our environment. There were satellite images, and I hope it's not fake news, over China or India about how people could suddenly see the Himalayas from cities in India because everyone's in lockdown, there's less pollution. And so maybe that's going to be a good message to people that, yeah, collectively we can influence our environment. So maybe that will combat this malaise about climate change. People
being the pessimist on the other side, Stephen, I think the amount of PPE, masks and plastic cups we've all used recently, you know, is causing problems in itself. There's a question you spoke about, how do we kind of learn for, you know, what might be another surge? And there is a question from one of the audience in terms of what systems should we put in place to learn locally in our health systems in order to approach or as a second wave might happen. I'm not sure if the questioner meant in general medical terms or whether they were thinking specifically with regard to mental health.
I think there needs to be a rise in digital healthcare. It needs to be more readily accessible. I don't know about the situation in Ireland, but in Canada, it's not very good. And we're supposed to have a great healthcare system, but the mental health is not good. It's hard to access. The waiting list to see a psychiatrist or psychologist is 6 months to a year. So it needs to be more digital care. And I guess what's important is community or grassroots programs too, of looking to the specific needs of particular communities in dealing with whatever problems are arising.
Making it very targeted to your own area.
Exactly,
and
yeah.
You mentioned as well about your kids going back to school and what might be the new norm. There was a question from one of the audience about, you know, maybe to expand that a little bit about what are the pros and the cons of kids going back to school in September?
Kids are manky, they're grubby, particularly younger children. Kids are vectors of disease. And that's been an issue in past pandemics, and that's why school closures are important early. And kids are just going to be, at least from my children and their friends, they want to get back to school, they want to socialize. It's a big challenge. When do you open up schools? If you open them up too early, you run the risk of a second wave. You delay it too long, it interferes with their schooling and their socialization. Predicting the optimal time to open up schools is immensely difficult. And you know, I got to hand it to the health authorities. It's a tough decision to make. That said, kids are adaptable, and they are, at least my kids have this grumbling resentment. They're adapting to online schooling, they're finding it boring and so forth. But I think what's happening though in Canada, at least, people are trying to find creative ways of having a mix of online and physical schooling. So opening up schools to, say, a small proportion of children going into schools to try and get schooling in a socially distant manner. So I guess we've got to be creative to make this work.
Well, just like you said about knowing your location, your locality, I wonder, like, some of the real negative impacts of not going to school are children where families can be very abusive with lockdown. And so actually going to school is a check-in with them, make sure they're safe. But even in terms of free meals, and not even talking about the social positivity and distraction that comes from learning. Do you think that, you know, countries should actually target certain groups and say, right, this is a socially deprived area, we're going to prioritize this group, we're going to try and have a way where those children are able to access school? The parents are often either unemployed or in low-paid jobs where they can't afford not to go working. So having kids at home further compromises the home.
I agree with you entirely. You know, we judge our societies by how we treat our most vulnerable populations. And parents who are trying to work from home and care for their children are experiencing a huge amount of distress. And then you add in all the other stresses. And this is in our research too. One of the biggest predictors of distress during lockdown are the various stresses. Homeschooling, job insecurity, food insecurity, and so forth. Yeah, unfortunately, governments have to step in and help people. And this is going to create massive economic consequences, but I see no way around it. Otherwise, you're going to see an increase in problems. We're already seeing a spike in divorces, and there's the issue of child abuse as well, with people under stress. So yeah, this needs to be addressed on a government level, as far as I can see.
And throwing another curveball at you, Stephen, because kids find it so hard to socially distance, and again, that was a comment by one of the audience, what about maybe just focusing on sheltering our elderly population that are most at risk? There have been, you know, kind of criticisms made about the experiment, as they call it in Sweden, where really many of the deaths were in the elderly population. Whereas, you know, what we've done very much here and in most other countries is making sure the over 70s, you know, stayed indoors for much longer, and even now are still very much cocooning. Do you think that we should maybe let the virus run a little bit more in the young group, accepting social distancing can't happen, accepting young adolescents and youth are in that slightly less believing about the negative impact, and put all our energy into really focusing on cocooning the vulnerable, the elderly, those with, you know, medical illnesses?
I can understand a rationale for that, that would protect the elderly and make the younger people wake up and smell the coffee, as it were, to take it seriously. But that's a real slippery slope. When you start that kind of herd immunity, you're really offering up lives instead of, you know, it's a slippery slope when you do that sort of thing. I'm not really a fan of that.
Yeah.
I mean, and the other thing with the elderly is the cocooning. That's fine and that's good, but people, some of the elderly people are feeling stigmatized. If they go out to shop, for example, they got to buy groceries, they're feeling ostracized or stigmatized or criticized. You're an old person, you should stay home. So there's that shaming issue. And then there's also the social isolation. And during SARS in 2003, there was a spike in suicides, and suicides were among the elderly who felt socially isolated and worried they'd be a burden on their families. So cocooning of the elderly is great from a physical health perspective, but we need to make sure that they stay connected. And in many countries, the elderly are not as technologically connected as the rest of people. So we need to make sure that they are socially connected if they are going to be socially isolated.
Right. Last question, Stephen, in the interest of time, by two participants. It's to talk a little bit about describing what did the psychological recovery look like in previous pandemics after that pandemic. I suspect it is maybe about the timeline or the clinical presentations, or how, the question is, what did psychological recovery look like?
That's a very important question. And although many of the phenomena we're seeing this time around are the same as what we've seen in previous pandemics, the aftermath has been really poorly studied. And that's because people tend to be myopic. And historians of pandemics have written about this, that once a pandemic is over, we rapidly forget the lessons we've learned. We move on with our lives and focus on whatever is in our immediate present. So after this so-called Spanish flu, for example, people moved on, just focused on it, and actually forgot the lessons. So there's not a lot that's written about the aftermath of that. If you go forward and talk about, say, the 2009 H1N1 influenza pandemic, that was a mild pandemic, so there wasn't much about that. What is the big one, though, however, was the SARS epidemic. It wasn't a pandemic. But after SARS, some people, particularly the people who were in quarantine who developed SARS and were on respirators, some of these people developed PTSD, and they might have recovered from SARS, but the PTSD continued. And SARS has been called a mental health catastrophe because we just didn't expect the degree of psychological dysfunction, or didn't expect it to be so chronic. So that's an aftermath we need to be looking to. I think particularly for the people who've been on respirators, for the people who've been quarantined on cruise ships, we need to follow up on these individuals and make sure that they're not lost to follow up, because they're at risk for developing enduring psychological problems.
So it's something we all need to be very, I suppose, we're still in the pandemic at the moment, but, you know, there will be different periods where there'll be relapses and remissions, but I guess it's to be mindful about that, you know. Yeah, and it's, in some ways, it's like very like occupational stress and burnout. It can take an awful long time before the performance cliff. And so I suspect many of us listening today, we're throwing ourselves into work. We're doing a very good job. You know, we feel perhaps we need to do that because obviously the demand is there. But I think every time we say we must look after ourselves as well. Yeah.
Absolutely. I agree with you entirely on that issue. Yeah.
Guys, we'd love to chat more. I know everybody has got work to go back to, and I hope you will all join us next week. Next week, you mentioned a little bit about, you know, the risk of suicide in the elderly post-SARS, and in fact, you made reference, Stephen, to the cruise ships. I heard some data, it wasn't in an academic source, but many of the staff on the cruise ships, there was a lot of suicides because they were also confined to the less salubrious quarters. And, you know, without any escape really. And in addition, family and financial issues were particularly key for them. But what we're going to talk about next week is a talk on the relationship between, or the concern, the risk about suicide and COVID, and drawing explicitly from previous pandemics, and I guess the link with the psychosocial adversity and unemployment in particular. And we have Professor David Gunnell who's going to be speaking, and he's also going to be joined by Dr. Pat Devitt, so that we're going to have the Irish context as well. So I'd like to end the talk by thanking everybody who's joined us today. And Stephen, thanking you very much for giving such a wonderful presentation.
Well, thanks
everybody
very much.
should go out and buy your book.
Thanks for inviting me. I really appreciate it. Thanks so much.
Bye, everybody else. Take care. Have a good weekend.
Bye.